to our short communication session on customer communication and professionalism. This has been such an exciting day with so much information, so much learning from a diverse set of presentations and talks from our distinguished speakers and guests in the first day of our inaugural Storm Med conference. My name is Lorainne Tudor-Car, and I'm Assistant Professor of Evidence-Based Medicine here at Kwong School of Medicine. I'm sure you will agree with me, so this will be a very exciting, interesting presentation, set of presentations for us to hear more about. So before I introduce our first speaker, please allow me to very quickly reiterate the format and guidelines. So each presentation will last 10 minutes, and then we will have 5 minutes for Q&A. We will open the floor for any questions that you may have. In case we run out of time to take your questions, please do reach out to our presenters after the session. I'm sure they will be happy to share more and answer any questions that you have over cocktails that are scheduled to take place after this session. So please allow me now to introduce our first speaker for today, which will be Mr. Ng from School of Humanities, NTU. And the title of the talk is Navigating Between Empathy and Knowledge Transfer, Preparing Medical Students for the Task of Updating in Clinical Communication.
So it's going to be a little bit of a double act. So I'm just going to start off, and then I'll hand over to Chian to take over. So this study was in the context of our clinical communication curriculum with Year 3 students. And at Year 3, the students are transitioning from the first 2 years where the focus of the communication curriculum is largely information gathering and history taking, to grappling with the concept of sharing information with patients for the first time in Year 3. And the setup is like this. For those of you who have seen our communication suite, we have large numbers of people crammed into one room. You can see here the student who is in the hot seat. This is the student who is who is interviewing the patient, and then this lady here. This is IMESP. This is the simulated patient, or in this case, the simulated relative in the situation. Other medical students observing, and then 2 facilitators who are observing what's going on and facilitating the feedback process. So in this scenario, the simulated patient is playing the part of a next of kin, the daughter of a patient who has just suffered acute myocardial infarction, and the task of the student is to update the patient's daughter about his condition. So the interaction takes place for 10 minutes, and you can see here the student busily updating the simulated relative of how her father is doing. So at this point I'm going to sit down and hand over.
Okay, thank you, Dr. Tanya. So now returning to the data itself. The methodology that we have employed is actually known as conversation analysis, or CA for short. This involves the moment-by-moment analysis of talk and other interactional features between 2 or more parties at conversation using either video or audio data in naturalistic settings. So in our case, we have extended the use of CA to the SP data we have collected from the LPC Medicine Year 3 Clinical Communication Training. And as supported by the literature, we believe that there is huge potential in using CA to examine simulated consultations for the benefit of students, enhancing their self-reflections, group discussions, and of course, communication training at large. So you can see that, well, for the purpose of this presentation, we've decided to focus on the video recordings of 3 students, whom we shall just call A, B, and C here. So these are the color indicator screenshots of the videos. One area of our interest is how the task of updating was being carried out by students. We realized that there were 2 different types of actions to which students need to orient to in the process of updating. One is about the transferring of medical knowledge and procedures. For example, like what kind of treatment was actually administered to the patient, and the other is addressing the concerns of the FP, or as what Tanya said, the relatively more precise, okay, and of course showing empathy to her. So navigating between these two issues is a task that students need to grapple with during their simulated consultation. So now let's take a look at a short video excerpt.
Is he okay now? Okay, so basically your father was treated for this heart attack. Okay. So just to tell you now, it was successful and now he's in the general ward. Okay. So maybe I'll just ask you, do you know what a heart attack is and what's your understanding of it?
So in this excerpt, the SP's expression of concern for a father's condition is treated by the student not as an opportunity to display empathy, but as a chance to deliver a narrative of what happened and general knowledge about the condition. In line 27, we can see that the daughter was clearly worried about her father when she asked, is he okay now? However, student A did not address her concern at this point in time. Instead, from lines 58 to 32, she launched into a procedural account of how the patient was treated for heart attack, that it was a successful treatment and is now in the general ward. Okay. And then she carried on in line 34 to check the SP's understanding of heart attacks as a means of ascertaining what further information needs to be delivered to the SP. So taken together, this excerpt shows an orientation on the student's part towards information giving over showing empathy and concern to the other party. Okay, now for student B.
Okay, so maybe you could tell me, what do you actually know about heart attacks?
My grandfather passed away from that.
Oh, okay. Yeah, so do you know what it is due to?
No.
Not really. Okay, no worries. So a heart attack happens when your heart doesn't get enough blood to pump. It does not get enough blood supply and it can pump the blood.
So here we show that student B in his preoccupation with launching an information transfer sequence misses two opportunities. One is the showing of empathy, and secondly is the possibility of doing some history taking for the patient. So in lines 41 to 43, similar to student A, student B actually initiates a sequence checking the SP's state of knowledge, which is actually what they've been taught in their medical school curriculum. However, instead of giving an account of what she knows or does not know about heart attacks, which actually will give the student some sort of straightforward go ahead to feed her with knowledge, the SP actually reported that her grandfather actually passed away from it. Okay. So at this juncture, right, the student have oriented to this as an empathic opportunity to address the underlying concern of heredity in the family, or even use this as to elicit more information for the purpose of history taking. Instead, any such attempt seems to have been aborted for an agenda of information transfer. In lines 45 to 46, he attends to the grandfather's cause of death in reference to his initial sequence to find what the SP knows about heart attacks, but the SP says she doesn't know what it's due to, and student B goes on to his project on knowledge transfer from lines 49 to 53. Okay, so we can actually see that the student gave up on the dual opportunity to enrich his history taking as well as showing empathy with the SP at the expense of transferring medical knowledge, and this reflects his strong intent to complete the original content delivery in a great preponderance towards information transfer. Okay, now for student C.
Okay. Yeah. So at this point, do you have any other questions about? I still have many things that I want to know. Okay. So I'll just continue first. Okay. So from there, then we gave him some oxygen to breathe, and we gave him some medications to thin the blood.
So in this last example, we show that a preoccupation towards delivering the medical narrative causes the student to lose sight of the other issues that the SP has in mind. And prior to this excerpt, actually, the student C was in the midst of delivering a sort of a medical narrative, and the opening lines here from lines 161 to 163 was to check if the SP has understood what she had said previously, and in more CA kind of technical terms, this is called asking for continual. However, in the next turn, the SP seems to have taken the question as a general one. Okay, and she said that she still has many things that she would like to know. Rather than addressing this issue, the student actually brushes off the SP's request and went ahead to complete her medical narrative from lines 169 to 172. And at this point in time, even though she said that I just continue first, seeming to ask for permission to continue, it was done very hastily without any opening for the SP actually to voice her disagreement. And you can thus see how the student's preoccupation with delivering this narrative impeded her ability to consider the sensitivities of the SP and the unfolding needs of the interaction in general. Okay, so in conclusion, we see many examples from our data. These are just 3 of them, highlighting that the students are actually first and foremost preoccupied with providing the SP with medical information during their consultations, rather than actually paying attention to the emotional displays of the SP. And there are thus missed opportunities to display empathy at specific moments in the interaction, and this could actually lead to breakdowns in communication. So while information giving remains a crucial aspect of medical consultations, we believe that students need to be made more aware of the other side of the task and be able to navigate in the 2 discourses with greater finesse and confidence. Yeah, so that's all I have, and thank you very much.
Thank you very much for your presentation. Any questions?
Did you feed back to those students those videos? Did they see them?
Well, they did not see them at this point in time because this project is still ongoing, but I think following on, you want to actually do something like that?
So there would have actually been feedback in the room. So if the facilitators had picked up some of these behaviours during the teaching session, then it might have come up during the feedback that, I noticed at a point when the patient raised the concern that, that you carry on talking about this, but it might have been an opportunity to also, address the patient's emotions at that point.
So the direct feedback.
So the facilitators in the room, if they spotted these kind of things, and of course conversational analysis looks sort of fine detail at very small bits of text, whereas what the facilitator is seeing is the overall sense of what's happening in the whole consultation, or it may or may not have come up during feedback.
Because that was my other question, really, whether it may come up later, maybe. But you don't, when that was settled, you've got the whole thing.
Yes, that's right. Yeah. So, like what Tanya was saying, this is like the structure of the whole session is that there's this similar consultation and there's this feedback session. So the first thing is present, to actually give immediate feedback. Right now, what we are doing is after this entire session, we are analyzing the videos. So, they did not receive this kind of feedback, but it's more of a general feedback, like what Tanya was mentioning.
Any other questions? So I have a question regarding the sample. How big was the sample that you analyzed this, and whether is this like a pattern that happened? And I wonder whether you would see maybe differences in terms of different years. Year 1, maybe
Okay, right. We have 30 recordings, and these are all from year 2. The reason why we took year 3 students is because they're at this point of transition between learning very basic communication skills to handling more advanced skills like breaking of so-called bad news and things like this. Yeah. So there's no comparison that I have within my data itself, but across the board, within this 30 students, we can see that there's quite an overwhelming pattern that they exhibit this kind of struggle between navigating in the 2 kind of discourses, as I mentioned.
Any final questions?
Can I just ask, are the students tested on their introduction? Because I didn't see that in how they introduce themselves.
Oh, so you mean at the start of the consultation, is that the case? Well, it's not shown in this in the clips that I have here today, but they typically begin by introducing their name to the patient, and after just a brief exchange of words, they'll jumping into the consultation itself.
And they confirm the identity of the relative?
Yes, they do. They do that. That's right.
So thank you very much again. And let's now welcome our second speaker today, Dr. Tanya Tierney, Assistant Dean,
So we've had one presentation looking at the context of Year 3 medical students. This is now moving to a particular session we have in our Year 1 communication curriculum, which addresses issues of language barrier. And we look at language barrier in a variety of different contexts, but with Year 1s, we look at the little shared language situation. And we know that, so we talked about the links between poor communication, medical error, patient safety, and also patient satisfaction. And we feel that language barrier is an important issue to deal with, particularly in the local context of a multilingual society, and often language barrier being prevalent in the clinical setting. So in this little shared language session, there's a variety of ways we could do that, but the most straightforward to deal with our linguistically broad students is to have the simulated patients portray patients who speak minimal English, so they can practice skills of kind of simplifying, clarifying, checking, understanding with a patient there's a little bit of a language barrier. And this study is looking at the session from the point of view of the simulated patients and the challenges for them in portraying this kind of scenario. I'm showing you a few videos with permission both from the simulated patients and also from the students involved, just to see before and after SP training some of the behaviours that we observed.
Hello, Madam B. I'm Lorainne. My name is Lorainne. Can I call you Madam B? Okay. I'm a medical student, and today I'm here to take your history. So, is English your preferred language? Can I speak English?
Very little.
Very little?
Very little.
But, okay, slowly. Okay, I understand. Madam B, just now, Jean, your niece, right? Is Jean your niece? Okay, she called us now, and she said that she's coming later to pick you up, you know, right? Okay, so later when she come, before she come, I'm going to tell what you tell me today to my boss. My boss will tell the information to Jean, so she also know what is going on. Okay. So, Madam B, may I ask, why are you in the hospital today?
Fall down.
So this was a before training video. And what we see from this is the patient is indeed speaking with minimal English. However, what we also see is that the student is actually quite verbose. And some of the sentence structures are quite complex. And there's probably things within that a patient with limited English may struggle to understand. But we don't see any evidence of her not understanding anything at this point. So it looks like there's sort of two processes. So for the simulated patient portraying this case, there's two processes they need to go through when they have a scenario like this. They need to make decisions about what words do I use, how do I describe the symptoms that I'm experiencing, but with minimal English. Remember, these SPs are fluent English speakers, so they're having to role play to pretend that they have limited English. So they have to think about the words they're going to use. Then there's a second process that they need to actually undertake within the role play, and that is making decisions and filtering what they're hearing from the students. So when a student asks a question, they need to think, well, what have I understood from that? And have I understood the question? In which case do I answer it? Or if I haven't understood it, what do I do? So this was something that we felt we needed to look at in a bit more detail and to do some work on with the group of simulated patients that we were working with. So within this session, we had 17 SPs that helped with this teaching session. And the scenarios were actually sent to them written in full English. And there's a couple of reasons for this. Firstly, I don't feel like I'm the person that's qualified to make judgments about how a patient living in Singapore who speaks minimal English would describe their symptoms. The SPs are a much better place to make those kind of decisions and to work out how they would describe certain things. And also the ethnic backgrounds vary in the SPs as well, and what someone with a Chinese background may differ from the words chosen from someone with an Indian background, for example. So the SPs take the cases written in fluent English and translate them and decide how they're going to work with them. And then they attend a rehearsal session before the teaching. And we had a questionnaire asking them, how did you prepare for this scenario? What did you do before coming to this session? And many of them talked about things like reading the scenario, writing notes about it, memorizing it, translating what was written in the scenario into what words they would actually use in minimal English, and rehearsing some of the phrasing. What we saw less often was preparation related to some of those more complex skills in terms of predicting what students might ask and how they would respond to those things. Actually role-playing it with somebody else at home, or going out into the streets and observing people who speak minimal English to see what kinds of things they say and what behaviours they're observing. We asked them to highlight what they thought was difficult, and there were some comments about both of those two tasks. Challenge to find the simplest word suitable for the scenario, for example. But then we did see some comments about the second, more complex skill, sieving the understanding of more complex words used by the student to act ignorant, easy to have little pauses. And this kind of pausing was something that worked very well in terms of when you pause to make that decision about how to reply, then that looks from an outsider as kind of pausing to try and understand what's being heard. So this skill of understanding and filtering and kind of pitching, how you're going to reply and whether you're going to understand it is a higher level skill than actually deciding beforehand what words you're going to use to describe your symptoms. And it has several steps to it. So we really wanted to focus on this second skill in the training. And here's some examples of some of the things that we identified as to what happened there.
Oh, I come for my regular checkup. Oh, my lot of problem. Diabetes, high blood, cholesterol. Need to take medicine.
What sort of medicine you taking? What medicine you eat?
The doctor medicine.
Okay.
So in this example, you see that the patient he's got stuck on a particular word where the student says, what sort of medicine are you taking? And she sort of rushes through that a little bit, so he doesn't hear that. So he's very cleverly decided that's the bit that he's going to find difficult to translate.
How long has the pain been? Since when did the pain start? 10 months. Okay.
So an alternative strategy, when there's something that the patient hasn't understood, they're just stumped by it and they kind of don't know how to respond and kind of do a little bit of confused acting.
So Maggie, why did you come to Polyclinic today?
I coming here backside paining, pain going leg,
Okay. So the pain will excite and go down again. When did this pain start?
Starting?
Yeah.
Starting here, and then going down.
Okay. So how long ago did you feel like this?
18 months.
I think this is probably what the more complex thing, this idea of misunderstanding, when actually the student has asked, when did the pain start? And she's decided, she's heard, where does the pain start? And answers in that context, and then the student is forced to rephrase his question to find out, what the duration of the pain has been. So just to summarise some of those decisions, so the student asks a question, and the SP can decide, have I understood the question, in which case I answer the question, or have I not understood it? And there's a number of things the SP can do in response to that. Look blank, demonstrate lack of understanding non-verbally, ask for clarification. Or they misunderstand, and then their response is to answer the question that they thought they'd heard. So we looked at the session feedback after the actual teaching session with the students, and we saw largely positive feedback. The SP was realistically reacting the way a linguistically challenged patient would, displayed visible signs of frustration because language barrier interactions are frustrating. And then from the facilitators as well, what they were observing, notice the increase in complexity of the students, that when the students asked questions that were phrased in a more complex way, that the SPs portrayed that they hadn't understood what was going on. And another lovely example of misunderstanding the student asked, "Are you coping?" And the patient says, "Yes, I'm cooking." And of course, just to give some balance, this is a challenging skill, and so just to give balance, I've included feedback where things maybe still there was room for improvement, and most of this was about just keeping the consistency of that language barrier throughout the interview. It's very easy for when the student asks a question, which the SB has of course understood, to just slip up and let it get through that barrier and answer it. And then of course the language barrier decreases. So the level of English also seems to vary quite a lot through the interview. So this is where the emphasis on the training needs to come. So in summary, pitching the level of English in language barrier scenarios, there's two processes. What are you going to say, what words they're going to use, and then this more complex skill of pitching, kind of filtering the understanding and responding to what the students are asking. Both these processes are of course important, but the second one, because it's more complex, that's where the attention needs to be paid during the training process for the simulated questions. Okay. Thank you very much.
So this is more of a question of curiosity, because I used to work in a hospital. Normally when a patient with minimal English appears, a nurse or some kind of translator will follow the patient. So I was wondering how much of this actually translates into actual practice. I know we've just graduated one cohort, but I was wondering.
Yeah, so it is, I mean, there's a level of artificiality about it. In often the language barrier, there's fluid, there's consultations going on, in English and Chinese at the same time, there's a bit of code switching going on. We work with the students to we sort of separate the skills slightly to get them to practice different skills at different times. So through years 1 and 2, we have 3 sessions looking at language barrier. This is the session in year 1 with the little shared language. And then in year 2, we have a session where the students are working with family member interpreters or lay interpreters, where SPs will work in pairs. Maybe the patient will be speaking in Hokkien, and then they brought his daughter with him to interpret. So the students can practice communicating through a third party. And then also another session whereby they communicate, we ask them, what second language would you like to consult in? And for the purpose of the sessions, we do ask them to keep them separate, so they can practice those skills, because it could be that they can code switch and have a sort of fused language consultation, but that may not be possible with all patients. It may be that the patient who speaks minimal English is somebody who's a native German speaker, for example. So it's just really looking at particular skills. I say to the students in this session, that if you have your patient is Cantonese speaking, and in this context speaking minimal English, but you speak Cantonese, please resist the urge to switch languages, just to allow them to think, what are the skills I'm practicing in this particular session?
Thank you.
I like that breakdown which when you talked about understanding and filtering. And then you were saying that as you need to be aware of this and find opportunities to show that I don't understand. And there are certain things that you can do to show not understanding. Some of the videos, as you know, I recorded in that talk. So one of the things that patients with little shared understanding quite often do in the clinic is they act as if they understand.
Yes.
So I was wondering if that could be part of how trained SPs act as if they understand, but not totally understand.
Yeah.
And see the students can pick it up.
Yeah, and there are examples of that, and it's a bit like our previous presentation. We're just seeing little snippets here that there's a whole host of different behaviours. And something we tell the students as well, that if you are, to be careful, patients may just nod, and also to be really careful about asking closed questions. It feels like the easiest thing in the world. My patient is struggling with English. If I move to closed questioning, it's much easier for them to answer. But of course, you can't guarantee they've understood the question. So, I mean, that behaviour, you're right, it is common, and I'm really looking forward to when we do some more work with the language barrier, with the real setting, to to kind of just see, and as we've just heard from Deborah and Stow, often what we're portraying with SPs may not always be as authentic as we think it is.
Great, thank you so much. Thank you.
Thank you.
Our third speaker today is Dr. Joanne, Deputy Head of Undergraduate Medicine at Imperial College. And the title of his presentation is Failure to Detect Low-Level Unprofessionalism in Undergraduate Medical Students and How to Effect Change.
Thank you. I'm going to be presenting today part of my professional doctorate that I'm doing at UCL in London. I'm Deputy Head of Undergraduate Medicine at Imperial College London as well. And I'm going to be talking about assessment of professionalism, and particularly why assessors sometimes don't actually mark students as unprofessional, and some of the reasons for that. So what are we dealing with, first of all? So these are students who just passed their A-levels, just on their way into medical school, looking very excited. And we know at the end of the 5-year programme that this is what we want to end up with new graduates with doctors. But it's not that easy. So becoming a doctor is more than just acquiring knowledge. In a session earlier on, I was talking about professional identity formation. And there is a sense that they need to change as they go along the way. Again, this is a picture of the doctor, which sits in the Tate Gallery in London. But you can see this very professional-looking doctor staring at the patient with great empathy. Maybe this is what we're trying to create, but how do we actually do that? So, challenging but important. Assessment of professionalism is particularly difficult. It's multidimensional, it's very context-specific. A huge study in Ottawa, in Canada, with Hodges and his group. A systematic review found 31 separate tools to assess professionalism. So there's a number of different ways of doing this. There's very little agreement on exactly how it should be done. And one of the big problems is often we talk about the professionalism definitions of honesty, integrity, these attitudes and values that sit in the definition. But how does that transfer to behaviour? So when we assess students, we're looking at behaviours. We're looking at how they're acting and being on the wards. And that's often very different. And we know this is important because doctors who are subject to malpractice cases at work are more than 3 times as likely to have been displayed unprofessional behaviour at medical school. This is a very important work from Dr. from California. And in particular, these are what we call low-level concerns. So unreliable attendance at clinic, failure to accept constructive criticism. So not necessarily major events, but small areas of professionalism. So the GMC have become very interested in what they're calling these low-level concerns, probably more common than previously thought, and specifically addressed in their new guidance, Professional Behaviours and Fitness to Practice. Most research into this has come from America, quite a lot from the nursing, from the social work profession, of this failure to fail of students with low-level concerns. But an example that this from a study in America is this group that people will say, oh, I would not tolerate this sort of behaviour. But in practice, they were passing the students. And I'm going to talk about some of the research into why that might be. So a little bit from the UK. Is it me or is it them? Factors influencing the passing of underperforming students. So Cleland and Rees interviewed 70 medical educators at 2 UK schools. And they found 6 main groups of why are the assessors not failing these students. And I'm going to go into those in a little bit. They then went on to discuss this reason for failing in a series of metaphors that I found quite interesting, because I think what we're talking about here is a human gap. We're not talking about something that's on a check sheet, but we're talking about why the assessor is failing to do this. And I sometimes think the choice of words is very interesting. So she divided this into 6 groups of metaphors of the kind of language these assessors were using about the students. So they would talk about the journey, passage, you have to get me back on track again. I don't want to be a hard man enforcer. So, sometimes a really hard language being used. Parentalism is a very interesting one. Quite a lot of the people I interviewed were looking at supporting the students. It's not my role to fail them. I think tough love is really important. And then at the bottom there, medicine, as doctors, as clinicians, we often use a medical metaphor to describe students in difficulty. So I think that some of this language is quite interesting. There's been a large Benia review looking at this issue more recently, so 5,330 articles, and 28 looking for why assessors fail to fail trainees. This is across nursing, medicine and dentistry. And again, 6 main barriers, but 3 enablers. So looking at those in more detail, fairly common. So the assessor's professional considerations. So if I fail the student, I'm going to have more work, I'm going to have to fill in more forms. The student might complain about me. And actually, maybe this is a sign I'm a poor teacher. If I'm failing the student, I'm going to get some comeback here. The assessor's personal considerations. So feeling personally that actually they're going to be failing the student, that it's their role to support the trainee. I've already spoken about this, that we are in a caring profession, so it's not in our nature to fail people. Trainee-related considerations, so what will be the effect on the trainee? If I fail them, maybe they can't enter the exams, maybe they'll need to repeat a year, they'll have financial cost to this, emotional cost. What will happen? Lack of experience sometimes on the part of the assessors, so not enough training of what the outcomes might be if you fail to fail someone. So I don't actually feel that confident with the guidelines. Have they passed or failed? I'm not sure. What would happen if I failed them? The institutional culture. So sometimes there's something from your university, from your institution. You have to pass the students, because if you don't, they'll stop sending the students and we'll lose money. And noticing that maybe previous assessors who had problems, that they had maybe a problem with promotion. So problems with the institution. And then considering the support available for the trainees. So some assessors felt, well, if I fail them, I'm going to have to offer them remediation and offer them another placement. And I've not got time for that. This isn't, I cannot go and do this. So 6 main reasons for why assessors might fail. And those of you who assess students might look at those and think, yeah, actually, I think I might fall into some of those categories. But on the positive side, 3 reasons why people would fail students. So a sense of responsibility, a sense of duty to society, that I need to fail the student, because if I don't, then they're going to go on maybe and cause problems with patients. That actually some institutions were very supportive, with policy, with informal support for the teachers, and so they felt able then to fail students when it was appropriate. And also knowing more about the opportunities for trainees. So if there were remedial courses, if there was opportunities to have mentors or other things, then assessors felt better about failing students. So I'm going to talk about what I did now. So I did a very small qualitative pilot study as part of my doctorate. I did some semi-structured interviews at my institution with 4 clinicians, 2 consultants, a GP, a general practitioner, and a junior doctor, about their professional values, what they understood by professionalism, and how they assessed professionalism. And I interviewed a medical student as well for their views about the process. And then I analysed this data using something called the Foucauldian discourse analysis. So I'm just going to, a little bit of a side now, why Foucault? Most people roll their eyes when I mention that I use Foucault in my research. So a really interesting man, a French sociologist and psychologist, lived within those dates in the 20th century, and really used discourse to discuss all the major systems. So he looked at health, he looked at madness, he looked at the penal system, and talked about power and knowledge relations. So his view is that power is capillary, so power moves from one person to another. Power doesn't sit in any one individual. And he thought, he looked for ruptures within these relationships that allowed a new discourse to appear. So this is highly relevant to the world of medical education. So if you think about it, there's a lot of hierarchy in our medical worlds. Increasing commercialisation, performativity, we're all being asked to fill in boxes that see a number of patients as well as teach the students. So there's a lot of this going on. And discussions about education versus research. But if you think about the capillary power not necessarily resting with one person, when the assessor is afraid that the student will complain about them, the power has shifted there. And I think that's quite interesting to think about. And I'm going to talk a bit more about that when you see my quotations. So I interviewed these people. I've generated 235 minutes of data. I use this 6-step analysis. And what this involves is looking at the kind of discourse people are using, what constructions they apply to that, and then what subject positions they take. And then finally, what's that subjectivity in that? I looked at those 3 main, what's called discursive objects: behaviours, as they relate to professional identity, appearance, and power and hierarchy. So as an example of how this works, I know this is quite wordy and educational. For example, if you look at appearance, and a lot of my some participants were talking about appearance, they might talk about the bare below the elbow code that has come into UK hospitals in the last, I don't know, 20 years or so, 10, 15 years maybe, as something being imposed by managers. So some of my participants said, well, you know, I don't even feel like a doctor anymore. I'm made to not wear a white coat and roll up my sleeves. I worry I don't even look like a doctor, and it's all down to the managers. And so they're taking that subject position of it being managerial control over their lives as describing their appearance and how they feel. So actually that brings me on to some of my findings. So some of the people I spoke to, so this psychiatrist was saying, well, it's all down to the higher training and exit exams, it's all out of my control. I can't possibly fail them because it's all just tick boxes, and it was all much better in the old days. And this is stopping me fail people because it's actually a training program, it's not me at all. The physician was talking about dress and saying, well, what he was saying was one of his bosses was bemoaning the fact, but actually it was him. It's one of these people talking about, my friend said, and junior doctors stop wearing ties, and it's devaluing your profession. And that's part of what sets the expectation. So feeling as if they're being deprofessionalised by this managerial control over what they wore. And again, and then they felt they had less self-efficacy to fail as students. So shift in power relations was a key finding. So junior doctors often will talk like this about, oh, well, what can I do? You know, the consultant signed them off, and then really there wasn't very much I can do. So feeling disempowered really by the system that has allowed something to happen, and that they can do very little to change things. There's some nodding going on here. And very interestingly, the GP I interviewed will say, well, I'm not the dean, I can't fail somebody. It's only the dean can do that, which I think is, you know, it's a bit difficult. We had 2,500 students, and I don't think the dean can go around and see all of those students and fail them on placement. But you can see that he didn't feel he had the right, despite the fact the student was sitting with him for 3 weeks, and he had worries about attendance and about timekeeping. He didn't feel he could sign that student off as being unprofessional. And some of these things are quite worrying. So where does this leave us? So having looked at my data and used this discourse analysis, I invented these clinicians, which are, I suppose, are like subject positions here. So clinician 1 is saying, well, professionalism, it's just another competency, the managers are in charge, I just have to tick boxes, so I'll just tick these boxes and get that form off my desk. And they would not sign the student off as being unprofessional. Clinician 2 is worried. So he or she is going to say, well, you know, it might be my own unprofessionalism that gets called into account. I might get a complaint, litigation, I'm going to have to go to an appeal. All of this, much easier to sign the student off. Clinician 3 is like the GP really, it's just too difficult. It's so hard now, they have to do so many things, and how am I to know? I've only seen them once or twice. I'm just not really trained enough for this role. Too difficult to assess. I'll sign them I won't sign them off as being unprofessional. And clinician 4, this very nice student, it's not my role, it's to judge the students, I'm really there to guide them. So this is this shift in the balance of power that I was talking about, that Foucault mentions as well. So all 4 of those, unfortunately, would not sign the student off as being unprofessional. But luckily, fortunately, we have our invented clinician 5 that would have one of those enablers. It's important to get this right. I need to do the right thing to highlight this unprofessional behaviour, and they would sign the student off. So 5 made-up clinicians. But how do we change practice? So challenging for all the reasons described above. There's a lot of defensiveness. So I presented this at a workshop in the UK with the GMC at tables like these, and people were sitting at tables discussing what their experience. And then we went around the tables, and we must have got around 2 or 3 tables before anybody would admit to saying, actually, yeah, I've not signed somebody off, I should have signed off. And so people are quite defensive about this, but it's happening, definitely. It is this human gap. There's often no checklist. We can't tick it off as a competency and say, yes, they've done this. It's actually a very personal thing. Institutional practice, really hard to change. But talking about it can help. So discussing it, bringing it out in the open, can show schools where things can improve. So it becomes really a faculty development issue. I think that assessors need to have more training. They need to know what would happen if they did sign a student off as unprofessional, what help that student could get, what support. But often it may not be that they couldn't actually pass the whole year, but they might have some extra support to help them through, and they need to know that really before not signing a student off. We need to simplify the whole process. Often there's too many forms, and it just makes it very hard for people to understand. The policies need to support the assessors as well, so that they don't feel they're going to be dragged through and made to feel that they failed if they sign a student off as unprofessional. And there's a need for a culture shift, which is easier said than done, but something that we need to think about. And then the GMC guidance I already mentioned, which actually has been very helpful and has set out a number of areas of these low-level concerns and what assessors can do to actually improve this. So thank you very much.
And we have time just for one question. Yeah, it's a very interesting topic, so much to discuss.
It's not a question, more a hypothetical scenario. It seems that the default is half a student. And if you have to fail the student, there will be a lot of process that you have to do. I'm just throwing the idea to reverse. So if you want to pass a student, you should make it difficult for people to justify why you have to pass a student. Right, so if you make it the other way around, it's easier to fail the student. I'm thinking in my context, I'm preparing someone for promotion. Right, so the process in organization when you get someone to promote is you should do a lot of preparation. So the default is don't do the promotion, because it's the easy way out. So I'm just throwing the idea to just turn things around, wouldn't make it really make any difference.
That's an interesting thought. I mean, in fact, most of our students are professional and most should pass. So I think you might have complaints from the clinicians who have to fill in more forms to pass them. And I think it might be unpopular. Interesting thought.
Great. Thank you so much. So let's move on to our fourth presenters today, which are Mr. Cheng and Ms. Lorainne, and they will be presenting on exploring the role of medical students in the clinical setting.
Good afternoon, everyone. So my name is Melvin, and this is Andy, and we're currently 4th and 5th year medical students at Imperial College London. So during our clinical attachment last year, we conducted a study focused on exploring the role of the medical student in a clinical setting, mainly to see how other people would perceive medical students when we're in hospitals. But before we delve deeper into our study, we just have a short video to show you. today.
Well, what this video shows, you might have seen it, is where the consultant comes in with a really nice car and all the students kind of just swarm around him. And what the consultant does, this is old times where the consultant can be really mean to students, kind of ridicule them and make fun of them and harass them when they answer questions wrong. And the students just kind of take it and feel bad about it.
Which, well, I mean, it's exaggerated for comedic effect. But, so I think the idea of this study actually stemmed from our own personal experiences whilst we were on this clinical attachments. And I think we felt that sometimes the importance of both students in a clinical setting and also the collaborative relationship between students and healthcare professionals can often be overlooked. And this can really negatively impact on team cohesion and also undermine the delivery of care. And so in previous literature, it was suggested that suboptimal interaction between medical students and nurses can lead to reduced student learning and a lower quality of patient care overall. And there seems to be a general unacknowledged tension between those who are involved in patient care, possibly due to their different roles and also the levels of authority. Now, therefore, we aim to investigate how medical students are really perceived by ourselves and also others in a clinical setting. So Andy will now talk through our methods and results.
So to set out to find out more about what our objectives are, we designed a survey where we went around Norfolk Park Hospital. We surveyed 75 individuals around the hospital in February, where we included inpatients, doctors, 30 medical students, and other HCP, essentially umbrella term for non-doctor healthcare professionals. What the survey consisted of is firstly 13 closed questions, generated on a Likert scale, where we asked them to rate a statement where they, on a scale from 1 to 5, from disagree to agree. And these 13 questions were designed around 3 key themes. Firstly, whether students are seen to be a useful entity in the hospital, so whether students bring value to clinical care. And our second theme is whether students are seen as a hindrance to clinical care, so whether students actually have a negative impact for patient care. And our third theme is looking at whether there's a perceived positive relationship between students and healthcare professionals. So what we did is we generated a median score for each theme, for each clinical role group, which allows us to compare between these role groups. So for example, we can see what doctors think compared to what students think. We also included some open questions where we asked our participants what they thought was the role of the medical students. And by using thematic analysis, we were able to draw out any interesting ideas or things that we did not expect to find. So moving on to results. So we firstly generated 3 figures for each of the themes I mentioned earlier. So the first one on the theme of where students are seen to be useful in patient care. This was a significant result. And it's not surprising if you look at the figures. So students in green, only participants that occupy the disagree side of the spectrum is students. Where everyone else thought students was, they're okay or whether they are a good presence in the hospital. Whereas there's a big chunk of students thinking we're actually a nuisance in the hospital. Then we looked at whether students have a good relationship with staff. This was a non-significant trend and we didn't find any significant results. And as most people thought, students have a good relationship with our colleagues. And for our third theme, whether students are seen as a hindrance to patient care, where we actually detract from our colleagues' ability to treat patients. Again, this is a non-significant result where everybody mostly disagreed with this statement, so occupy the left side of the spectrum. So, emphasizing some other results, we performed some post hoc Manuel-Whitney tests on each individual question, so our 13 questions. And we generally found that students, again, have a negative perception about students being in hospital, that we actually have a negative impact, whereas patients reassuringly think we have a positive impact in hospital. For example, when we asked our participants how much they agreed with the statement that students have played an important part in patient care, students rated this significantly the lowest compared to all other groups. And when we asked our participants whether they think students make a useful contribution to patient care, So when we make a useful contribution to patient care, patients rate this significantly highest compared to all other groups. Now, on a separate set of questions, we asked our participants to rate how patient-centered students are, and then how patient-centered our doctor counterparts are. Interestingly, patients and students rated students to be more patient-centered than our doctor counterparts. So we think we listen more and we take more time to take into account our patient perspectives. So on the whole, it seems that we are really appreciated by patients, but students ourselves are very self-critical of ourselves. Moving on to our qualitative data, where we asked what the primary role of students are. 95% of our participants said that our role is primarily along the lines of learning, whereas only 36% said something along the lines of assisting or performing useful jobs in hospitals, such as venipuncture or doing examinations. So which implies that students have somewhat of a passive role in hospital, where we're just seen as there to learn, observe, learn, and internalize information, rather than actually being a useful part of the team. And interestingly, we also observed that there's a very surprisingly low response rate to our open questions by our non-doctor healthcare professionals. Only 40% of the non-doctor healthcare professionals we surveyed left a comment, whereas somewhere along the lines of 80 to 90% of doctors, patients, and doctors left a comment, which we believe this implies that healthcare professionals, non-doctor healthcare professionals, are either too busy to interact with students or just not too eager to interact with students. Now I just pass on back to Lorainne for conclusions and discussion.
So just to summarize our results, so our study established that the main role of a student is to learn. However, we also found that students tend to undervalue their own usefulness in the medical team, and this is critically important because a prolonged period of negative self-perception can lead to negative learning motivation and therefore compromise the future patient care when these students grow up to become our future doctors. Now, on the other hand, patients seem to value students a lot more than students themselves or any other professionals on the medical team. And this reinforces, I think, the importance of students in the delivery of high-quality patient care. Our qualitative research points to a lack of interaction between students and non-doctor healthcare professionals, as shown by some of the feedback and a lower response rate from open questions, as commented on by Andy. And thus, guided by our questionnaire responses, we identified 3 main strategies with which we can implement to both help to improve student and healthcare professional relationship, and also boost student self-perception. So firstly, we thought that we should try to incorporate non-doctor healthcare professionals into our curriculum. As we learn from different healthcare professionals, we will gain a variety of skills, learn to appreciate their work, and also this will help to improve future doctor-healthcare professional relationships. Now secondly, we need to assign students more responsibilities when they're on the wards. So in contrast to the current DOB system, whereby it's just basically you go in and you sign it off like a piece of paper by the doctor who's in charge on that day, we came up with the idea of developing a game app through which medical educators could assign students daily quests to complete based on their clinical teachings, and through which students could compete with peers or earn real-life rewards. Now we envision that this might help students to not only reinforce their learning, but also empower students to maximize their sense of purposefulness when they're on awards. And hopefully this will help them to feel a bit more useful, I guess, when they're on their clinical placements. And thirdly, and perhaps most importantly, I think what we should try to do is to improve the cultural and teaching environment that we're in. Because currently students perceive themselves to be obstructive in clinical settings. And this may be due to how some healthcare professionals are interacting with our students. We should make sure that we are setting realistic expectations for our students, as well as giving feedback that is constructive. Working in an environment where we can embrace mistakes and be open to learning is perhaps one of the most important lessons we can pass on to our future doctors. And yeah, and thank you very much for listening. We'll be happy to answer any questions.
Okay, thank you for the presentation. That was really good. My area of research actually is serious gaming. So you have, let's say you have an app that your clinician could use to send you a request throughout the hospital. How much development have you done on this, or is this just an idea? Because implementation of such games, normally they seem simple at the start, but once you start going to the technical details, the cost will skyrocket, the manpower will skyrocket, the amount of work you will give to clinicians will skyrocket, and they'll be very
Yes.
like what to you. So have you done any development of such an app?
Okay, so I completely understand what you're saying about the cost, because obviously when we came up with these strategies, we also considered sort of a cost-benefit ratio of these. In essence, we haven't actually started to develop a game app yet, but we are hoping to get in touch with one of our lecturers, who's actually, I think, running a workshop at this conference on how gaming could help with medical education. I don't know if you guys know James Moss, but I think he's the one in charge.
Tomorrow, right?
Maybe, possibly. I'm actually not sure.
Okay.
Tomorrow, okay. Yeah, so we're hoping to maybe have a chat with him, and also have a chat with some of the sort of student leaders in our year groups, and see what they think about this idea of bringing this game app. And I think we want to get some sort of feedback first about the general idea before we delve into actually developing it.
Have you used any serious games at the moment? Because I forget the name now, but there's one serious game, millions of downloads now. It lets you gamify your life. So it will, after you choose a set of themes at the start, it will give you a quest for the day. For example, go to the gym, brush your teeth. I mean, the brush your teeth is a bit too extreme, but go to the gym, check your emails, and once it's done, you can check it off yourself. Of course, this will require some level of trust. I forget the app now. It's 20 eyes on me, it made me forget. But it's there. Such a thing does exist. But I also think maybe try to reduce the clinician involvement, because that may reduce the chance of it getting implemented. It's just less work for the busy people. I will try to look for the app to do it, but that's all I have to do.
So I think I actually did have a similar app for myself. It's sort of like a checklist app, where basically you can set tasks for yourself during the day, and every time you check off something on that, like an item on the list, you get to slay dragons and gain rewards, etc. And I thought it was just a really fun idea. So yeah, I guess that's some of where the original idea of our game app came from.
Very interesting. Thank you very much. Thank you for sharing. Fifth presentation by Mr. Melvin from Imperial. The topic is conceptual medicine. The topic is holistic learning in early clinical exposure, qualitative data, and effective pricing.
Good evening, everybody. My name is Melvin, and I'm a final year medical student from the Chian School of Medicine. And so today I'll just be sharing a little bit about some work that I did.
Yes, sorry. So just a brief introduction. So my work aims to investigate what first year preclinical medical students learn from early clinical exposure when you shift emphasis away from gaining academic knowledge and instead focus on reflecting on personal and professional growth. And the basis of this project was because in LPC medicine there is an early clinical exposure program that we call Hospital Week. And what this essentially is a week that first year medical students spend shadowing various departments in a hospital setting. And they are supervised by a senior doctor and a senior nurse, co-supervisors. And at the end of this week, a reflective assignment has to be completed by every student as a course requirement. And just how early is our early clinical exposure? So I did a nice little graphic. This is medical school, hopefully. It's not so linear usually.
It is linear.
Or smooth sailing.
Yeah, it may not be as smooth. Yeah.
Yes. And where the hospital week is roughly right there. Actually, it's in the first month. It's in week 4 of the first year of medical school. So this is really early, before any real clinical knowledge or experience has any chance of setting in. And so what we did was we collected a total of 198 write-ups from our students, from 2 cohorts of our students. We assigned randomized them, assigned some numerical codes, and we randomly picked 20% of these anonymized reflections for qualitative analysis. And these writings were given to a single author to code using grounded theory, and after preliminary analysis, the authors would meet to discuss the categories and coding choices. And this process would facilitate the coding of new themes, and if there were new themes identified, we would repeat the process, pick another 20%, do everything again until saturation was reached. After which a further 10% of the reflections will be picked to confirm saturation. And in total, we analyzed a total of 100 reflections before we reach saturations. And I just want to share our results. So actually, students discussed quite a few major themes, but for today, I'd like to just focus on what we classified, or what we call the patient's journey. And how we define the patient's journey would be discussions that would convey the patient's perspectives or experience through the healthcare system. And this could start from presentation, recovery to discharge. And it will also include issues that our patients would have to go through living with illness. And the most common sub-theme, yeah. So as you can see, the most common sub-theme is that of the patient's perspectives, but there were others, as you can see. And actually, I've picked a few choice quotes here just to keep things interesting. So the first one, it actually conveys what students share about the stress and uncertainty of illness. They would describe it either vicariously or from recounting what the patients have shared. Some also talked about dealing with the impact that illness can have on the patient's family or close ones. And also, some of them will recount the patient's journey through the healthcare system, both the good and the bad. And because so many of our students shared about some aspect of the patient's perspective, we decided to further analyze further analyze the patient's perspectives. And what we found that students would have reached their own different understandings of the different facets pertaining to a patient's experience. And as you can see, so as you can see, I have more choice quotes here. So the first one would be students' discussion on the dignity. In this case, it would have been just dignity in the wards or in illness, but some of them also discuss dignity in dying as well. some also talked about facing the limitations of modern medicine, the financial burden of sickness, as well as the environment in which the patients have to live in every day. And so this brings me on to discussion. So we've kind of looked at what students have gained from their experience in terms of a unique appreciation and understanding of what patients go through in the patient's journey. But what this tells us is a few things. Firstly, that early clinical exposure at this early stage of the medical career allows students to appreciate and experience the patient's journey as close as they can without being patients themselves. This allows them to contextualize their learning, foster professionalism, and maybe not from analysis of patient's journey, but in some of our other analysis, it was discovered that students will have realizations about how they're developing their communication skills and as well as their professionalism. And in fact, this is facilitated by the pair of senior doctor and senior nurse co-supervisors that I mentioned at the start, who challenge the students and provide different perspectives of healthcare and inculcate interprofessional collaboration, instill empathy, and emphasize on good communication skills right from the beginning, from year one. And so early clinical exposure has given students more time to familiarize themselves with the humanity and the practice of medicine before they can begin to medicalize and before they can begin to medicalize the patient's experiences or become desensitized themselves. And through reflection, students are actually encouraged to interpret, personalize, and process and express their experiences to further develop their perception of medicine. And in fact, our analysis of the reflective writing at this point allows us to improve our understanding of how they developed so early on in their medical career. So, keep things short. Medical workplace learning takes place right from the start. And early clinical exposure is really the opportunity and reflective writing as a very viable tool for students to remind themselves that doctors are first a carer before they are a care deliverer. So that was short and sweet.
So I have one question. I noticed that you used ground theory in your analysis. It's a very challenging approach to qualitative data analysis. Please elaborate a little bit on that point.
Well, I had help from my supervisor, who is Prof. Kang.
And another supervisor. He has two supervisors.
I'm not very sure how to answer your question. Prof, maybe you want to engage.
Why don't you talk us through what you did with all the reflective writing first?
Okay, that I can do. So I received the reflective writings, and so what I essentially did was I pored over every one of them to look for patterns or things that I could justify as being a theme of some sort. After that, it was pretty much just finding a pigeonhole to put my findings in, and then so I did this for the first 20%, and I went back and discussed it with Prof. And we ended up doing a lot of discussion about how we're going to define the pigeonhole per se. Yes, and so we keep revisiting our definitions, and at the end of everything, that's how we came up with the definition of what would fall under the patient's journey. There were actually 3 major categories that we found. Each of them we defined a certain way. But essentially it was just going through everything that they said, and after, at some point, patterns start to emerge, and then you just kind of stop them the same way. Yeah. And that's just
How much time did you all take?
a lot of
Less than
coffee.
Thank you so much. So our last speaker for today is Mr. Kang from Young Yes, and the title of the presentation is Three Generational Home Care. So very longitudinal student-initiated home care program on secondary school student participants, ages, and teaching.
Everybody. Jonathan, I'm a second-year medical student from Lorainne School of Medicine, National University of Singapore. Today I'll be presenting on actually a community care project that I'm actually involved in and doing research for. So the title is as follows. And we'll actually be looking at the ages attitudes of our secondary school participants in the project. So these are the contents I'm trying to cover in the short 10 minutes I have. So I think first and foremost, I'd like to address what is tri-generational home care. It's actually a student-led, professional supported program by Tudor-Car Hospital. So basically we work with them as well as the Northwest Community Development Center, as well as various secondary schools which send their secondary school volunteers to us. So we actually attached to Tudor-Car's Aging in Place program. So Aging in Place program is like a program in which we try to shape patient care from the hospital to the community, and this involves this is certain criteria that they have to meet. So the patients to be like warded for more than at least 3 times in the last 6 months to qualify for this. And so the patients were then selected by Tudor-Car and recommended to us for admission to the Tri-Gen program. So what makes Tri-Gen different from the conventional community care project is that it's longitudinal in that sense. It's over 6 months. Interestingly, it involves 3 different key stakeholders. First and foremost, we're looking at the elderly patients themselves. Secondly, the healthcare undergraduates from different faculties. So we actually have students from LKC and NUS Medicine. We have students from NUS and SIT Nursing. We have occupational therapy and physiotherapy from SIT as well. Pharmacy and social work from NUS. So we try to bring all these people together and to basically try to improve things like medical compliance, as well as to teach them how to be more self-efficacious in terms of caring for themselves. So the objectives of our study were as follows, actually the project as follows for the secondary school students. Firstly, to reduce ageism. Secondly, to improve their knowledge of older persons in general. This is, I think, relevant given Singapore's aging population. Thirdly, is more of a soft skill, which is the development of intergenerational bonds, understanding as well as social awareness. The program design was as follows. It's actually still ongoing, the project, but we actually collected data specifically from 2015 to 2017. So that was actually our cycle 2 to cycle 6, and each cycle is about 6 months long. Prior to the commencement of each cycle, we actually had a half-day training session conducted for both healthcare undergraduates as well as secondary school students. So what we tried to teach them was like trying to address elderly misconceptions. For example, the secondary school students would actually be involved in like gamification. So for example, like they would wear gloves and try to put on clothes just to get a feel of the kind of difficulties the elderly face in their daily lives. Or for example, wearing those like plastic cups with cut holes so that you can like simulate blurry and limited vision, things like that. And then after all this training, we'll actually send about 5 to 6 secondary school students paired with 2 to 3 undergraduates to the patient homes. And what we'll do there is we basically try to teach the secondary school students as well as the elderly on how to take their vitals, for example, BP, blood glucose measurements, things like that. And In line with our focus on interprofessional collaboration, we also actually held multidisciplinary meetings at the 3-month and 6-month mark of every cycle. So what this means is that we actually try to bring whatever progress we made the first 3 months to a multidisciplinary team consisting of a social worker, a pharmacist, a doctor, and where possible, a physiotherapist as well, and share with them what progress we made, and then they would give them recommendations on how to improve. And then they would convene again at the end of 6 months to see whether the patient's fit for discharge from the TriGen program. So the methods we use were as follows: 2 validated scales. First is the Kogan's Attitudes Towards Old People scale. So we use that to assess their levels of ageism. Second one was Palmore's Specs of Aging, which as it says, we have to assess knowledge about aging itself. And the stats tests we use were PET t-tests of independence, as well as the chi-squared trend test. So here are key findings. And I'll start with demographics first. So from 2018 to 2017, we actually about 224 secondary school students. Mean age is about 14.8. So we're looking at probably Sec 2, Sec 3 students. Well, a minority of them were male. Yeah. And these are some of the other social demographic factors that we try to collect from them, such as whether they had siblings, past voluntary experience in an old person's facility, whether they stayed with grandparents, as well as finding that response rate. So here are some of the key findings. So firstly, we found that pre-post TriGen, they had an increase in their Kogan's as well as the Palmer score, which means to say that they were, in that sense, they displayed improvement in the ageist attitudes, as well as improvement in their knowledge of older persons. And the stats are as follows. So then we then tried to actually break it down and compare and see whether there was any correlation between social demographic factors with the changes in score, and we couldn't find any. So these are just the p-values. One thing that we did find, however, was that there was a weak but statistically significant correlation in their Kogan score, which Kogan's is the ageism one. So we found that the more time we spent with the elderly, then the greater the change in the score. So yeah, and not so for Palmer's. So which brings me to my discussion. We did some lit reviews, and we found that actually the pre-cycle Kogan scores were actually well above neutral. So it ranges from 34 to 204. It's a 5 I think it's 5.6. It's a Likert scale, yeah. Sorry, my bad. Yeah, and it was higher than local junior medical professionals in a paper by Lee and Wong in 2009 in the Annals of Academy Medicine in Singapore. So we posit that young have fewer preconceived notions of the elderly. Another thing was that to note is that the ageist attitudes as well as their knowledge of older persons also improved even without formal geriatrics modules in our program. So it's more like just exposure in terms of difficulties that elderly face and things like that. So we found that we believe that hands-on experiences can potentially help to broaden participant perspectives and lessen the ageist attitudes. Finally, with reference to my last point of discussion about the improvement in ageist attitudes, we would like to think that all POTS contact theory is actually plausible because TriGen actually establishes the 4 elements that are required for positive contact, which is an equal status in the sense that we try to bring everyone to learn from each other, common goals in terms of interaction, patient care, intergroup cooperation by the 3 groups that we try to bring together, and finally institutional support from our partners at Alexandria Health, as well as the Northwest CDC. Yeah. Some of the limitations that we acknowledge came out during our research was that there's lack of longitudinal data on long-term outcomes. Secondly, was that all these were self-reported, because these skills all self-reported, for soft skills. And finally, most of these students were also self-selected in the sense that they had to volunteer for the project. So this kind of limits the generalizability of our results. So future directions in which our project intends to take will be efforts to determine the specific elements which would reduce the ageism and increase knowledge specifically, as well as potential long-term analysis and scores to see what kind of impacts Tri-Gen will have on the secondary school students and the team leaders in the long term. So we believe that Tri-Gen has the potential to correct pre-existing ageist attitudes and improve their knowledge through increased contact with the elderly, as well as with each other. And finally, we believe that service learning projects with very, very specific educational outcomes can then be powerful tools in educating our secondary school students beyond the classroom. These are my references. Thank you very much.
Any questions?
Did you collect data from the patient's perspective?
Yes, we did. But that was done by my friend who's not presenting at this conference. Is there anything about the patient data that you might be interested in?
You should be the one telling us.
Okay, sure.
Yeah.
I think we did a case analysis, and so one of the things that we actually found is that statistically is not very significant because of the very stringent criteria that Tudor-Car set up for admission to the program. But I found that in terms of self-reporting, they reported that they were more compliant to medication. So for that, we actually used the MMAS for the Morinsky adherence scale. Then we also used a 6-item self-efficacy for managing chronic disease, and they also generally reported that they were in a better position to improve their health.
What about qualitative data from the patient? Are they happy to have secondary students?
Yes. In general, yeah, they saw the secondary school students. Interestingly, they saw the secondary school students as more like befrienders, and rather than actually being part of the provision of healthcare. Yeah, exactly. So they tended to see the team leaders, the healthcare undergraduates. Oh, these are the people that are coming down to do the checks. So when we tried to get the secondary school students to actually do the BP measurement as well as even do the finger prick for blood glucose, they were a bit apprehensive, but we explained to them, or at least what we told the TLs to do was to explain to them that we're actually trying to teach these secondary school students some of these skills so that they can bring home to better take care of their own grandparents and own seniors at home. And then they were then more accepting of that. Yeah.
Any final questions? So thank you very much.